Hi, welcome to PK's classes. Today we will study congestive heart failure and its treatment. Congestive heart failure is a condition in which the cardiac output is inadequate to meet the demands of metabolic demands of the body during exercise and ultimately at rest also the cardiac output decreases, so the blood supplied to tissues becomes less than their demand. So we can say the heart fails to function. Heart fails to function. So there will be congestion of the heart. So we call it congestive heart failure. Okay, so to understand this, let us discuss two terms. One is called preload and the other is called afterload. And preload and afterload total we can call the workload of heart. So the work of heart is that the main function of heart is to pump the blood to different tissues. Okay, so these two things affect this workload, preload and afterload. And preload is nothing but your venous load, and the afterload is nothing, your peripheral resistance is equal to peripheral resistance, because this is the pressure on the arteries. This is related to your artery. Okay, that means veins take blood from tissues to heart, then from heart through arteries the blood comes out. So the load exerted by the venous blood, the load exerted by venous blood on heart is your preload, and the load exerted by your cardiac output coming out of blood coming out of heart on arteries is afterload. So this afterload will be equal to your peripheral resistance. So now when there will be a heart disease or increase in preload or increase in afterload, the cardiac output, which is the amount of blood ejected by heart per minute, decreases. So this leads to decrease in tissue perfusion, and this is called your heart failure. Okay, so this leads to your heart failure. And when the cardiac output decreases, and tissue perfusion decreases, so to kidney also the renal blood flow will decrease, and this decreases the renin release, and renin is involved in the renin angiotensin system. So this inactivates the renin angiotensin system, so there will be less angiotensin 2, and angiotensin 2 in our previous class we have discussed that angiotensin 2 causes vasoconstriction and increases the peripheral resistance, and angiotensin 2 also increases the secretion of aldosterone which causes the salt and water retention. So this salt and water retention increases the central venous pressure, because of which the preload increases. Okay, and when the cardiac output decreases, so ultimately there will be increase in central venous pressure, which increases the preload. So ultimately day by day the heart becomes more and more congested, and when this peripheral resistance increases, this increases the afterload. This increases the afterload. Okay, and now this how we can treat this disease, this congestive heart failure. We have to target this one. We have to increase the cardiac output. This is one target, target one, and then we can also block this renin-angiotensin system. This is target two. Okay, or we can use this salt and water retention. Salt and water retention, we can target 3 by use of diuretics we can give. Okay, and uh, we can the sympathetic action, this renin release, that can be also blocked by the target 4. Okay, all these things we can do, but the major target in treatment of congestive heart failure is increase in cardiac output. So, to understand the increase in cardiac output, we have to understand how the contraction of heart is regulated. So, if we take a myocardial cell in which there is a calcium channel, and we have the L type voltage gated calcium channel. Okay, and calcium enters into the cell. So this is outside and this is inside, and this calcium is required for contraction of the um, cardiac muscle. So contraction of cardiac muscle is caused by your calcium, contraction of cardiac muscle. And two more things are there, two exchangers are there. One is called your sodium potassium ATPase. Okay, sodium potassium ATPase. Sodium potassium ATPase in the ratio of 3:2. So 3 sodium in exchange of 2 potassium. So sodium potassium ATPase is there, and there is one sodium calcium exchanger. Okay, so sodium comes in and calcium goes out. So this is called sodium, and this is in the ratio of 3:1, sodium calcium exchanger. Okay, so this sodium calcium exchanger works simultaneously with sodium potassium ATPase. So sodium potassium ATPase takes 3 sodium outside in exchange of 2 potassium which comes inside, and the sodium enters inside in exchange of calcium outside. So the cardiac glycosides, we have cardiac glycosides which inhibit this sodium potassium ATPase. So when sodium potassium ATPase is inhibited, this sodium concentration inside, this increases the sodium concentration inside. So inside sodium concentration when increases, it inhibits indirectly this one. So inhibits sodium calcium exchanger. So no entry of sodium from outside to inside will occur. So there will be no exchange of calcium with sodium. So this leads to, if sodium will not come, calcium will not go, the calcium concentration now will increase inside. And calcium is required for contraction of the cardiac muscle. So when calcium increases, it leads to contraction. And there is a mechanism, calcium binds to troponin, and there is actin myosin binding, and there will be contraction of the cardiac muscle. So cardiac glycoside are the drugs, positive inotropic drugs, which increase the force of contraction, and we can also use drugs like beta 1 agonists, beta 1 receptor. So beta 1 agonist can be used. Beta 1 agonists like dobutamine can be used, which increases the force of contraction. And uh, uh, we can also use this beta 1 is a G protein coupled receptor, and this G protein coupled receptor is linked to adenylate cyclase, so there will be increase in cyclic AMP, and this cyclic AMP is converted to inactive 5-AMP by phosphodiesterase. So phosphodiesterase 3 is there, so PD3 inhibitors can also be used. PD3 inhibitors can also be used, like so PDE3 inhibitor, for example amrinone, milrinone, milrinone. These drugs can be used. So three positive inotropic drugs, can be used. One is cardiac glycosides, two is beta 1 agonist, three is PD3 inhibitors. Okay, and what other drugs we can use? From this we can see other drugs which we can use in addition to the positive inotropic drugs are the inhibitors of renin angiotensin system, like your SCE inhibitors and AT1 receptor blockers. Okay, and we can use vasodilators here. We can use the vasodilators like organic nitrates like glycerin nitrate, and we can also use diuretics which may be your loop diuretics, and the thiazide diuretics like furosemide, thiazide diuretics we can also use. And in addition we can also use the beta blockers if because when the heart will be congested, there will be increase in sympathetic activity, and for that, so this will lead to increase in sympathetic activity, and to block that we can also use beta blockers. So beta 1 agonists we will use when we want to increase the cardiac output, and when we want to block the sympathetic activity we can use the beta blockers. And also you can use these aldosterone antagonists. So in diuretics also we can use aldosterone antagonists also, spironolactone, that can be used. So with this is over.